Hello and welcome to the CSF Rheumatology Author Interview Podcast. My name is Professor Peter Nash from the Griffith University in beautiful downtown Brisbane, where today it was 34 degrees with 90% humidity and not one case of COVID in the whole state. I am joined today by my friend and colleague from the University of Vienna in Austria, Andreas Kerschbaumer. And I'd like to welcome you, Andreas, and thank you very much for giving up your time. And we're talking about a paper that was in RMD Open, and it was recently published accepted and published June, August of this year. And it's talking about a major collaboration from a bunch of people that Andreas is going to tell us all about, who put together a paper that's evidence-based. Once physicians have decided that they're going to use a Janus Kinase inhibitor, then what they should be aware of, know about, understand, monitor, screen, side effects to look for those treatments across the immune-mediated diseases. And this was based on a systematic literature research, which Andreas did. So congratulations, Andreas, for the amount of work you must have put in to put this together. So can you tell us first a little bit about yourself and the work you're doing in Vienna and the department that you're in and what their research interests are?
Hi, Peter. Thank you for having me. So I am from Vienna and I'm working at the Medical University of Vienna. I am part of the team of Professor Advocacy and Professor Smolin, and we're working actually on, so once Daniel called it, we do basic science in clinical science. So we look for effects in clinical trials and the way clinical trials are done, which may affect the outcomes on clinical trials in rheumatology, and especially RA and PSA. And I am mainly focused on doing meta-analysis, looking at huge effects on clinical trials that you may not get when looking at patient-level data, because you may not have the data available. You will not have available data of 10 or 20 or 50 clinical trials at one time on a patient-level databases. Therefore, we try to extract data from the clinical trials that is on a public domain and investigate effects of different population effects or drug effects or study effects on the outcome of clinical trials. That is actually what we're doing.
And it has been really groundbreaking. Daniel's been involved in the Boolean remission criteria, the AACR-EULAR combined task force. So it really has been very critically important, getting all those outcome measures and understanding the data in clinical trials. Tell us a little bit about the consensus, and then tell us a little bit about how you did the systematic literature review.
So this was a consensus initiated actually by you, Professor Nash, and Professor Smolin. And it was actually initiated in the year 2018. And the main problem we had is that before the discovery of JAK inhibitors, we actually had only one drug class to exhibit broad efficacy across many different diseases. And these were TNF blockers. And now we had 2 decades of experience with TNF blockers, but we still had limited experience on JAK inhibitors across different diseases. And therefore, the idea was to accumulate all the evidence that's out there in clinical trials and make an evidence-based consensus, focusing on all the issues doctors are facing in clinical practice when they use or when they decided to use a JAK inhibitor. And this task was not only built up of rheumatologists, but we also had a dermatologist and hematologist included in the task force to help us answering that question. And what we did is, so it was the DSLR was actually done in the EULAR way. So we have EULAR standardized operating procedures that we followed. And after our first steering group meeting, we developed research questions to answer through this SLR. And then a study protocol was developed by the methodologist, which was Desiree van der Heide and myself. And we included all the relevant patient populations, interventions, so the different drugs we wanted to look at, control groups we thought that were important, and the outcomes that we thought were important. And then with the help of a database expert, we started to do the search and searched Embase, Medline, the Cochrane library to include all the studies of all the different diseases. And this was not just RA, this was also PSA, ankylosing spondylitis, systemic lupus, Crohn's disease, ulcerative colitis, alopecia, and atopic dermatitis. And from the earliest index dates until March 2019, and it's almost a problem with SLRs, you have the time point they're published. Actually, the data is already old, but that's something you cannot get around with, or we have to get around with. And whereas
So
we include, yeah.
So tell us, you took all that literature, must have been thousands of articles, but
True.
you also took presentations at AACR, EULAR, and meetings and abstracts, because otherwise it would have been very out of date very quickly.
True. That's why we also included conference abstracts. Exactly. But it still gives you the problem that you have not the possibility to have all the outcomes you want to look at. You only have certain outcomes available. You cannot do the risk of bias analysis on certain trials as you do not have enough information. Yeah, so that's kind of limited data when it comes to data quality, but you have the data available, and I think that's important.
And it's such a rapidly moving feast. It just changes. There's new articles all the time. So the cutoff was around the March 2019. Okay.
Exactly.
So tell us a little bit about that methodology, that design. Was there PICO questions? Was there a grade analysis? Was there a bias analysis? What did you do?
So EULAR is actually following the Oxford recommendation. So we have the Oxford stratification for the level of evidence. We do not think that grade is helping us a lot when looking at a smaller amount of evidence in certain diseases, that it would lead to only having conditional recommendations after all. I think, and that's actually what Professor Smolin always emphasizes. He's not very convinced that this helps us a lot when summarizing evidence, and I'm fully agreeing regarding that with him. And we.
So tell us. Sorry, keep going.
Yeah. Then you start off with this database search. You have thousands of abstracts available. There were about 2,500, and I screened them and extracted about 300 reports that I thought were interesting and important for our questions. And then I get into detail of these reports, and 72 of them were then finally included for analysis. And we did the risk of bias analysis using the Cochrane collaboration tool for risk of bias assessment. And yeah, actually that's the methodologist's part and methodological part to do. And then
you focus a little bit on efficacy and on safety.
Yeah, we mainly looked at efficacy. There was not that much there for safety, so we had to look at the efficacy data we had, especially from randomized controlled trials. And then actually the most of the safety data we had available was from randomized controlled trials. And then we extracted also the safety data and long-term extension data and also looked at that.
And no registry data yet, but that'll be important eventually. So, you know, the papers you rejected, what was the problem with them? Why couldn't you use that data? Was it not controlled? Was it not randomized? What was the problem with the reject articles?
So the problem with reject articles was mainly regarding safety, that you have no proper control, and you may have methodology used. So retrospective data is very hard to use if you don't have a proper control. This is the main reason when looking at cohort studies. And when looking at efficacy studies, we only focused on randomized, controlled, double-blind trials. We were not interested in open-label trials. We were not interested in a cohort of 10 patients investigating one drug without a control group in a rare disease. This is something where you cannot drive much out of it.
Fair enough. So tell us a little bit about your findings, mainly on the efficacy side, on the safety side. What were your findings in the paper?
So we had about 72 reports included for the assessment of efficacy, and I think there were 6 JAK inhibitors that were of major importance. This was tofacitinib, this was baricitinib, and pefacitinib, upadacitinib, filgotinib, and disarnitinib. These were the 6 JAKs that were widely studied across several diseases. The majority of the data was available for RA, and the efficacy was shown across several diseases. We saw efficacy in RA, in PsA. There were some trials already going on in ankylosing spondylitis, in SLE, a bit of a data in psoriasis, ulcerative colitis, and Crohn's disease. And
so that was a massive undertaking, really.
It was quite some work, yes, especially as you have to focus on different diseases and very heterogeneous outcomes and interpret them in a way that it makes sense to the readership, even if you're not a rheumatologist. And I'm a rheumatologist in training, and so I'm kind of used to the outcomes we use in rheumatology, but the biggest and major difficulty was also understand outcomes that you're not really into and that you're not speaking fluently, let's say it like that.
Yeah, it must have been very challenging. Inflammatory bowel disease, atopic dermatitis, that was a real challenge. But you did include experts in each of those fields to get some help, I hope.
True. So actually, while doing the first part, I actually remained on reviewing the literature myself and looking at the data myself. We did include the experts. We did include the gastroenterologist in the task force as well to discuss important questions on Crohn's disease and ulcerative colitis during the task force meetings and during the steering committee meetings to also include expert opinion on that.
Okay. And then can you tell us anything about your findings, efficacy findings or safety findings?
I think the most important efficacy findings were included in the RA studies. We had quite some studies available for tofacitinib, baricitinib, and upadacitinib. Filgotinib, the trials were just coming up at that time point. And I think the major findings were derived from the head-to-head studies we had available back then, which were oral standard and oral strategy from tofacitinib, and the RA beam study for baricitinib and select compare for upadacitinib, where tofa 5 milligrams BID plus methotrexate showed non-inferiority when using the AACR outcomes to adalimumab plus methotrexate in oral strategy, and bari 4 milligrams as well as upar 15 milligrams, also with concomitant therapy with methotrexate, demonstrated statistical superiority to adalimumab plus methotrexate. I think these were the main findings, and these were the first drugs to show and to be superior in a statistical way to adalimumab, to
the gold standard. Yeah. So that was pretty. I think that really established the JAK class moving forward. Now, what about safety signals that stood out? The zoster thing, the VTE thing, are big issues around the world. And were you able to get some clarity on that safety side?
So I very well remember when we were sitting there in March 19, we had I think a week before, the safety warning of the EMA just came out, and actually we were discussing this quite heavily as the data which was available to the regulators, it was not available to us back then. So we knew about the BCE issue, but we actually didn't know how they derived the data exactly, as we didn't have the data at hand. These were the safety studies, and the data actually was locked. We didn't have the chance to look at it. So we also included this kind of gray literature to derive important caveats the user or the clinician has to have when using JAK inhibitors in clinical practice. But we did have data on herpes zoster rates. We knew that zoster rates were higher in patients treated with JAK inhibitors, and we also knew that this was especially a problem in the Asian region.
Right, and then I recall there was the large consensus meeting where they had representatives from all over the world, experts in all the different diseases, IBD, psoriasis, patient representatives, imaging representatives, methodology representatives, and you presented the SLR to help people come up with the recommendations and the findings. Can you tell us a little bit about that?
You mean what the SLR concluded?
Yes, and how the SLR then guided them moving forward.
Yes, so the SLR actually, what I did is just present them the data as it is, maybe in a way that helped them to group it and to put it into certain boxes. So we started off with RA, where we had the hugest amount of data available, and then we went to PSA and ankylosing spondylitis. And actually, first we had a huge efficacy part where we discussed, or I discussed or showed the data of the different clinical trials and across different outcomes. Then we went over to safety, looked at lipids, looked at infection rates, also looked at potential pregnancies that occurred and vaccination studies which were available.
So it was a massive undertaking. We congratulate you for the amount of work that you did. Any take-home messages from the SLR for rheumatologists in current clinical practice?
The take-home message is that I think the JAK inhibitors are the second big step in rheumatology after TNF blockers. And we see effects beyond TNF blockers. We see direct effects on pain, very quick onset of the clinical symptom relief, and further, I think we have a very special safety profile, which brings us into we need to ask our patients more questions than before regarding the risk profile. I think it has a lot of possibilities also for certain patient preferences, but also for clinician preferences. You can stop the drug quite quickly, and you do not have to wait for 2 weeks until the drug is gone. And actually, and I think that's the most important point with JAK inhibitors, if they if we get a generic JAK inhibitor, this may be a huge opportunity for low income or poor countries which have a poor healthcare system, as you do not have to have a cool chain to use the drug. You can use the drug in Central Africa and have millions of people having a very effective drug available.
So that's very promising, isn't it? And something we look forward to. And one of TOFA's off patent very soon, 22, 24, something like that. So that'll be a whole new world. Do you think we need a patient version of the recommendations? That's one of the things I've suggested to Joseph, because it seemed to be popular when you did the EULAR biologic recommendation.
Mm-hmm, mm-hmm. I think this would be a good idea to do. I think many patients have a lot of questions, and I think as patients now are very, very informed about their drugs and want to know more about them, I think it would be a very good idea. also to inform them about the risks that we doctors face and why we are asking certain questions, why we are doing certain blood tests. I think it would be a very good idea also to inform patients.
Excellent. And lastly, before we let you go, do you think with this field moving forward so fast with so many publications, when should we update what you've just done? Next year, the year after?
I think in 2 years. I think the problem with updates is if you come up with not many new things, the update is just a lot of work and doesn't add much.
Right.
I would wait maybe for another 1 or 2 years when all the trials are out. There's not that much going. Maybe there is not that much going on in rheumatology, but there may be a lot of more trials coming up in other diseases like atopic dermatitis, for example, and maybe we also have registry data and proper safety data available in about 2 years. I think this would be a fair amount of time.
Excellent. And we might even see a JAK to JAK switch study in a year or two's time, which might be interesting.
I think these are the trials we should really wait for, as we then really would make sense to update.
So we thank you again for your time today, Andreas. We know you're very busy. This has been the CSF Author Interview Podcast. If you'd like to know more about this paper and others uploaded to the CSF website this month, detailed slide sets are available in the publication section at cytokinesignaling.com. Please subscribe to this podcast on iTunes or wherever you get your podcast from and give us some feedback and let us know what you think. Thank you very much, Andreas. Great to see you, and I hope you stay safe in lockdown.
Thank you, Peter.
Thanks.